Welcome to the podcast of Hemisphere, the official journal of the European Hematology Association. Hemisphere's podcast presents insightful, expert discussions about recent hematology publications. We hope you enjoy.
Welcome to this episode of the Hemisphere podcast. My name is Stephen Hibbs. I'm a hematologist and clinical research fellow based at Queen Mary University of London, and I'm one of the scientific editors for Hemisphere. So in this episode, I'm joined by my friend and colleague, Dr. Joe Taylor, to talk about some themes that were raised in a paper I wrote last year called "This is Going to Hurt: Reapproaching the Patient Experience of Bone Marrow Biopsies." I'm going to talk a little bit about how we're trained, a bit about how we talk to patients about bone marrow biopsies, about how we talk to each other as clinicians, and some of the outstanding questions about bone marrow biopsies and the patient experience of them. So Joe, if I could turn to you now and ask you to introduce yourself and to let me know your initial memories of first watching and then performing bone marrow biopsies.
Yeah, sure. Hi. So I'm Joe Taylor. I'm in my last year, just finishing training in a couple of months on the East London rotation, Hematology Ridge. And yeah, I've worked with Stephen over the years. As far as first memories of learning how to do a bone marrow procedure, my memory is of as an SHO, and my initial memory is that I thought the needles were enormous and that I thought it was quite a brutal procedure to witness first time. And then to do it, I think we probably both taught on a kind of see a couple, try it out, and with the kind of, my memory is being told that we're in a safe area and there's not much else you can hit. And I think that's still something that is a narrative around bone marrow, and that and at the time it was also very much you kept going until you got the sample, and I think if you had started and it was sore, people went back with more analgesia, but actually they kept going until they got a sample. And often that's fair because they really need the sample. The sample's for an important purpose. But I think things are probably better from that point of view now, and I see more people calling for help and changing operator if they're struggling. But yeah, I think that's my first memory.
So I think one of the things that surprised me most when I was reading about bone marrow biopsy experience in preparation for this article last year was about the disparity between some of the earlier literature about pain, and particularly persistent pain, and some more recent smaller studies. So specifically, I know some of the big UK studies that sort of informed some of our complication rates that were led by Professor Bain maybe 20 years ago or 15 years ago, something like that. They reported really tiny levels of persistent pain, sort of less than 1 in 1,000. But it was all clinician reported. And so I guess what you've got to have there is both a patient who feels enabled or has been asked about their pain, and then a clinician who takes it seriously enough to actually own that as a complication and say, yes, that is persistent pain. And so studies in which they looked at this and actually followed people up and asked them actively have shown that most people still have pain several days after, a good number, for weeks, and even by, I can't remember if it was months or a year, but really quite a long way away, it was about 5% of people who still have some persistent pain, which I think is quite a surprise. And so I now do warn people about that when I'm consenting them for biopsies. The other thing I really try and warn people about is the moment of aspiration, because that just seems to be something that's quite unpredictable, that some people won't notice it at all. But I say to people, when I'm consenting a patient, something to the effect of, some people feel a really unpleasant pulling sensation at that moment. I will warn you before I'm going to do that, and it will only last a couple of seconds if that is the case. But again, I really try and highlight that, because I think a lot of it is moments of surprising pain that feel out of control are so much worse than moments where you are expecting pain. I really like your counting down from 10 thing, because I've not done that before, but I think that's a great way to acknowledge there's pain, but to kind of signpost to it and to limit it. So yeah, is there anything else that you kind of tell patients about pain?
I mean, I suppose in the same way, actually, it also signposts to the relative who's often there to hold hand, and they kind of help them through that bit, which does Yeah, I think from pain perspective, actually, is it what you were saying about the Barbara Bain study, which actually I don't want to talk down. I think it's a really important study. It looked at 20,000 bone marrows, and the conclusions that it made was that complications were rare, but there were significant rare complications. The problem is what we've drawn from that is incorrect, and what you commonly hear is people saying it's a very safe procedure, and we really don't know that actually, because that was a study that was done before the electronic health record. You're definitely right. All that stuff about whether we are declaring and recording properly, whether people are having complications. This is a study where we've written to each hospital and said, how many bone marrow procedures have you done, and what complications have you reported, which is wildly different from a collection over time. And I personally have seen many. I've seen complications. I know of deaths. I know of a series of so I'm very confident that the complication rate is significantly higher than what we're seeing in that study. And I think it's not to a criticism of the study. I think it's down to the way that data was collected, and we need to understand what that data means and what it does not mean. And it does not mean it's safe, or it does not mean it's exceptionally safe. It is a safe procedure, but it's not an exceptionally safe procedure. And I think interestingly about what you're saying about prolonged pain, totally uncaptured in that study. And there's other elements to that I think are important. So I read a study saying that 15% of bone marrow trephines asymptomatically hit the SI joint. So that's an enormous percentage. And actually, I spoke to our histopathologists. They say they frequently see cartilage in the trephine. We are hitting that joint. And if you get SI joint pain, and sacroiliitis is a recognized finding after bone marrow biopsy, and if you get that pain, firstly, SI joint pain will not feel like pain at the spot of the biopsy. It'll radiate into the buttock, so they may not associate with that pain with the biopsy. They may have myeloma and a lot of other pain otherwise. But also, we're doing this in young people, and we don't know if you puncture and take a core out of an SI joint, what that's going to do in 20 years' time to that joint, for example. So there's a lot of uncaptured stuff there. I think going back to other complications rates, because I should have said about consent, I also do consent for death. I say exceptionally rare, reported in 1 in 30,000 marrows, I think. I say severe bleeding, exceptionally rare, but can happen. And then I go through the series and I cover common and you should know about, but I do mention death because it does happen. It is a recognized thing, and it should be recorded in the consent.
Reflecting on everything you've kind of read and learned about bone marrow biopsies and safety and experience, and if you could kind of redesign what a bone marrow biopsy service unit would look like, what are some of the sort of key elements that you want to be involved?
I mean, I suppose there's minimum, there's desirable, and there's what I believe it should be. And I think desirable and really minimum is the kind of stuff you were describing earlier, the stuff about making it a more pleasant experience, making sure that we are taking the time to just pay respect to the fact that it is a significant procedure that some people are psychologically scarred by, and some people have a lot of anxiety build up to, making sure that we're aware of that and dealing with that anxiety and not kind of minimizing it, saying it's going to be fine, don't worry about it, let's just get on with it. I think the truth is, looking back when I was a house officer, it was completely acceptable to do a pleural tap blind on the ward with minimal training, and I did. And now we recognize that there's a pneumothorax rate to that, and people won't even do it. Even it's only the respiratory registrar with an ultrasound. And I think that we should be finding out in more detail what the actual complication rates are. And I really think that in an ideal world, this is a procedure that would be done in an anesthetic room with an anaesthetist, with proper monitoring afterwards, and the option of sedation if people wanted it. And I actually think ultrasound guidance could do a lot for safety. I'm sure it would reduce the hit rate of the SI joint, which I think is an important thing. And I think who knows what damage that does. I think it would give us more confidence. I actually think it would mean we'd anesthetize better, because you're always aware that you've got 10 mils of lidocaine and you want to use it in the right spot. I think if you could lie someone prone, do it with a bone marrow, but with an ultrasound, and know exactly where you're going, you would then be able to spend more time making sure that anaesthetic is right and delivering it properly. I think those are the kind of main criteria that I'd say that in my sort of dream thing. And I don't really think that's such an unreasonable thing. I think it's lack of engagement with the anaesthetic service, and I wonder if it's because as hematologists we're slightly isolated from the rest of general medicine, because all these procedures that were commonplace when we were early in training are no longer done that way, and the reason they're no longer done that way is safety and cleanliness as well, actually. And we've got immunosuppressed patients, just to add that in. And so I wonder if we just need to evolve as hematologists and move in that same direction. And yes, that will need considerable inconvenience for us and redesign of our service, but maybe that's just what should happen.
I've been struck at thinking about other departments like in endoscopy as well, where a lot of it is that there's a sense of focus on doing one thing really well. And I think bone marrow biopsies are often not like that. You're kind of sitting in the same waiting room as people who are coming for transfusions or chemo or blood tests, and you get fitted in when you do. You might have a rough time slot, but there's a sense of there's not really a sense of calm and of the elective nature of what it is really, which is something that's planned. I've thought about how ideally I'd want to have a conversation in advance of the day of just so someone heard my voice and I could talk to them about some of these things and probably send over a video that's particularly kind of goes through it a bit in advance, and that there was the sense that someone wasn't just kind of picturing this anonymous practitioner who was going to come and do this, but actually they'd spoken to them and there was hopefully some rapport that had been formed already. I think there's actually a few things that have shown to be effective. I think tramadol for aspirate pain, there's good enough evidence, I think anyway, that apart from perhaps for those who've had lots of aspirates and don't get aspirate related pain, I think that would be a very reasonable thing to do. I think sedation, as you say, having that as an option and it not just being this kind of thing you've got to go the extra mile and everyone's a bit grumpy about it because it's hard to arrange, but actually that just happens for anyone who wants it. Perhaps with, I guess that there would be situations in which you'd have to have a really careful conversation about the particular risks for particular people. But I think a lot of the time that isn't what it is. It's more just like, this is a lot of hassle and there's not good systems in place to do this. Yeah, I think just to treat it as something more akin to an endoscopy or something where you've come in and that's what people are focused on and that's what a service does, will just lead to people thinking more in that way rather than as this is the thing we do on the side and we just get it done. That I think as a whole way of thinking would change this. I was going to ask about training as well, because that's I think an important part of the puzzle and something we both talked about, feeling that hadn't gone in an ideal way for us, even though I know I've had plenty of supportive colleagues who've helped me along the way. But what's your thoughts on how bone marrow biopsy training could look?
I think I completely agree. I think it could and should be a lot better. I mean, I think that there should be a much longer process of teaching. There should be much more recognition and acknowledgement that the goal of the bone marrow biopsy is not to get a good quick sample. It's to get a good quick sample with minimal discomfort to the patient, and once you take that into account, then actually the process should have longer and better training. I think that actually it's a procedure that goes a lot better when two people are doing it, and that we don't do that because it's inconvenient to us and we don't have time. But actually, if we had a longer kind of supervised training process, then we would have people that were much better operators, much kinder operators, and delivering safer and nicer bone marrows. I think there's a lot of training around the procedure that's not done at all. I was told when I started, this is the spot, feel for this bone, go there, it'll be fine, there's nothing near there that can go wrong. That's factually not correct. And actually, I learned the anatomy retrospectively quite late. And actually, when I talk about the anatomy to people, there's often a bit of surprise and looks of anxiety there because at the end of the day, we're focusing on a spot that's about 1.5 centimeters across. If you go to lateral to that, you can slip and give a gluteal tear. as you slip down the bone, and everyone's experienced that feeling, unfortunately, and that will give a month of pain to the patient. But also in there, you've got significant large vessels and you've got significant large nerves. And then if you go laterally and medially rather, just a little, just half a centimeter medially, but deep, is the SI joint, and a little bit more medially, you will hit the sacrum, and the sacrum, you won't know you're hitting the sacrum because it has bone marrow in it. So you'll be coring, you'll get your result. It'll just be deeper than you expect. But the major nerves travel through the sacrum, and you can eat. And I know of cases, I know of bleeds and a death post bone marrow. That tends to be in people first presentation with an MPN. I know of people who've had sacroiliac nerve damage that can take a long time to recover. I know there's a whole list of complications, firstly, that we're not consenting for well, but also I think lots of operators are not really aware of. And the difficult thing with big people is it's fine, you're right. It's true to say if you're in the right spot, you'll be fine. And if you angle correctly, then you'll core deep and you can core a long way. And 2 centimeters is the optimal sample, which is great. But actually the depth, if you're not at the right angle to the SI joint, is less than 2 centimeters. So that's one of the reasons why we're hitting it. If you're not angling correctly, not in the right spot. And in a big person, you're feeling what you think is that spot in the bone, but you might be way off. And if you're way off target, then those complications are firstly really important for us to understand and know about, so that we can recognize what's happening if somebody's having a vasovagal, the new MPN having a vasovagal 30 minutes post-procedure could be a significant bleed into the pelvis, because we could have gone all the way through, or just knowing what kind of complications could happen and how we should deal with it. And actually, I think that would help people calm, help people feel better about that they knew what they were doing, and also mean that we got better samples and better results. And I think ultrasound being cheaply and easily available, relatively cheaply, answers a lot of that, because suddenly we can say, I know that I'm angling right, I know that I'm in the right spot, and I know that my 2 centimeter core isn't going too deep and into somewhere dangerous, because 2 centimeters is what we aim for, but it's a long way. And in a big person, a needle that long can be this far in, which is a long way, and actually makes me feel anxious, and certainly made me feel a lot more anxious when I didn't understand the anatomy properly.
Yes. Yeah, I think a lot of it really comes down to just taking it more seriously, really, like in all of these areas. And I think the sort of literature that I could find when I was looking up training, as I read the article last year, was only really in the sort of nursing and allied health professional literature, and that was fairly brief. But one of the striking things was, I think this particular program was suggesting, I think it was 100 supervised procedures, or at least 50. It was a lot, which I don't know how many I did supervise, but it was nowhere near that. And so that's one part of it. I also wonder about, just learning from the surgical specialties and others about the role of simulation, of models, of virtual reality, even like actually a lot of it is, people say a lot of it's just experience, but that learning curve, we could probably get a hell of a lot higher up that learning curve before we're with another human, through some of those models, actually. So I think
experienced and unsupervised experience is not the same thing.
Right. Yeah. Right. Exactly.
I agree.
Exactly. So I think there's both a place for more direct supervision. I mean, I remember coming as a 3rd-year registrar who should by then, in my mind, be really good at bone marrow biopsies, and just having to go to the best person at doing these procedures in our particular unit, who was a physician's associate. So in the UK system, that's someone who would support physicians and could be very skilled in a lot of different tasks, but isn't medically trained. And this particular person was brilliant, a brilliant kind of operator. And I just said to her, look, I should know how to do this better than I do, but actually, can I just come and do a couple of days with you, where I just watch you watch me? And that was so good. By then I'd done a lot, but actually getting some feedback, getting some, even after if we were picturing a kind of training system in which you have a lot of supervision at the start, having supervision later on as well, where people are really sort of carefully, just some of it wouldn't someone would just be sharing good practice of saying, here's something you don't have to do, but actually this is how I've got around this particular problem in the past. Yeah, I guess it all starts with the admission that this is a bigger deal than the sort of general discourse around it has implied.
That we need to learn to do it, not just to do it, but to do it well.
Yes, exactly. So final question then, research, and this might connect with that point of just taking this more seriously than we have collectively in the past. What do you think are the most important unanswered questions in this area of bone marrow biopsies that could be addressed by research?
Well, I mean, I think as we've kind of covered, like the Barbara Bain study was really important, but I think we're now 20 years on rather, and it's kind of pretty disappointing that we can't really sit here and say we know precisely how safe this procedure is. So that's number one. Like we need to, and that's not just how many people die, because this shouldn't be about how many people die. We know that's very low. It's what's the morbidity of it? What are the complications? What exactly is the complication rate? How should we be doing it better? I think there's so many things that we could be looking at from a research perspective on this. And they're really topical. I mean, even the news not that long ago was somebody going sternally with a bone marrow biopsy, trephine needle, how that could ever, I mean, that was an SI event, but, that's entirely, but it is an issue, it's a live issue. And I think that there are, I think it's disappointing that we don't know this already, but I think there's a lot of research opportunity to know how to do it properly and how to do it better. And as I've said probably a couple of times now, not just how to do it, but how to do it as well as it can be. Because, I mean, AML is a terrible disease. AML is a disease that is just devastating. And people are so scarred by being in hospital. If they're more scarred by repeated bone marrows, just from a kindness point of view, that's something that we could and should be doing a lot better than we are. And if we can just reduce that, then that's a major win. And actually, for kind of reasons we might be poor at it, is I wonder as soon as it's going to happen to me soon, as soon as you're a consultant, you don't need to do them anymore, or very rarely need to do them. You look at the results and that's important, but the kind of reality fades. And the memory of your good bone marrows probably sticks around more than the memory of your bad ones, because you're thinking, oh, I'm better now. But actually, I don't know what proportion of bone marrows as a whole among practitioners are good bone marrows and how many are bad bone marrows. But that balance could be shifted a long way. And actually by I'm going to try and remember as a consultant to this that I still care about this, and this is something that we should continue to push on, because it's easy to fade into the less important things as your focus shifts to other things. But
yeah, I think the only thing I'd add to that is that probably that question of what a good bone marrow looks like needs to be about good bone marrows for different body shapes as well. And I think that particular question of if you have got a lot of if your fat distribution overlies your posterior iliac spine, what is the best approach, and what measures can be taken to make that safer? And that probably overlaps with a lot of what you said, but I think that's that feels like there's a sort of injustice or inequity or something in our
it's not acceptable to say it's just going to hurt more for you. That is not acceptable. So it needs to be addressed, and we should know enough about it as to how to address it.
Well, Joe, thank you. I've really appreciated your comments on this and the discussion. I think we've covered a lot of ground, and thank you to all of our listeners for listening in today to this Hemasphere podcast. We'll be back soon with another episode.
Thank you for listening to this episode of the Hemasphere podcast. All of Hemasphere's content is open access and can be found at www.hemaspherejournal.com. We hope you will join us for future podcast episodes.